Hello, Kim Nelson here with Max Shapiro. We're guests of Dr. Schegelov today and plan on kind of covering some interesting conceptual framework for endovascular treatment of aneurysms. I'd firstly like to begin by thanking Max. Max put together a lot of these slides from our NYU practice, so there are a number of cases drawn from over the years and assembling it in a nice PowerPoint presentation for today's discussion. I'd like to frame this context, the whole lecture, the whole discussion, conceptually, though. It's frequently we fall into a problem, a difficulty of like, or a focus on the technology, what's available, new tools. But there's a philosophy of endovascular that I first learned from Alex Berenstein and Pierre Listenius. Max has continued this attitude. That's very important. How, as a specialty, do we look at disease, and how do we frame the context of our therapies and our treatments? So yes, we have new tools, but you can see here on this pictograph old tools as well, clips, coils. When I first got into this business, and the father of Dr. Schegelov was around, there was a different approach, and many of the things that we would do endovascular to treat aneurysms really came down to deconstructive approaches, what we call parent vessel occlusion. So you would take a massive aneurysm growing off of a parent artery, and you would occlude the diseased artery as well as the aneurysm, and that's how we treated it. Well, conceptually, that can be thought of as flow diversion because you're changing the flow in that vessel to address that aneurysm. And so I'd like to, as we go through these cases, I want to frame the context of flow diversion in this background, this history, which is so important, related to how did endovascular approaches develop and where do we see the new tools being applied.
Kim, thanks so much. We want to, first of all, thank Professor Scheglov and his institute for hosting us. And we want to thank RAZOM for Ukraine for organizing our missions here. This is our third mission together with Dr. Nelson, visiting various places, Dnipro, Lviv, Kyiv, working with many highly talented physicians and groups with strong tradition, going back to, the times before interventional existed in most parts of the world. There was already a neurointerventional tradition here. And so this is going to be kind of part of what we touch on here, is how to carry the tradition and how to go from one treatment to the next. The tools change, but anatomy remains the same, and the concepts of disease are also applied to the old and the new tools together. So there's some disclosures. And I do mention that I am a consultant with Medtronic, which is a manufacturer of the pipeline device. Most of our experience and most of the cases you see here will be for flow diversion, will be pipeline cases. So the concept here is basically what we want to develop. I think in a talk, it's important to have a few points, central points that we go back to and we emphasize kind of over and over again, because this is something that people remember and you take away from a lecture or webinar or whatever. The point that we would like to make today is that historically, when you think of what we call flow diversion, there is something called like kind of direct or classic flow diversion, and then there is these other kind of newer areas like, well, can we flow divert the anterior communicating artery? What about distal flow diversion, right? What about posterior circulation? And so this is like this concept of direct versus indirect flow diversion. Okay, do you know what I'm talking about? Like, okay, so basically, what this relates to is kind of a historical location, anatomical location where flow diversion was introduced. The early studies, like PETA or PUFs, of which Dr. Nelson was the principal organizer, focused on the carotid siphon, on the internal carotid artery from the petrous segment to the ophthalmic segment or later to the carotid terminus. That's sort of like the classic area for flow diversion. But that's looking at it from a more of like an extravascular perspective, like where is this location in the brain relative to other intracranial structures. It's not really looking at how the vessels themselves are organized, because there is variation in how the vessels are organized in that location. So as we go through this talk, we want to encourage you, instead of thinking kind of an anatomical location like the siphon, to more think of in terms of the vascular anatomy in each particular location where the aneurysm is. Because that's ultimately more important, like whether flow diversion, quote unquote, works or it doesn't, or how to apply it, more depends on how the vessels are organized around the aneurysm, regardless of where that aneurysm happens to be. It could be an anterior communicating, could be pericallosal, could be posterior cerebral artery. It's more about the relationships of where the aneurysm is in relation to other branches. That's more important than the location itself.
Let's just go back to that previous slide. I bring this case up just because we encountered it downstairs a few minutes ago, but this is typically a large cavernous aneurysm that you see there on the left. And there's a construct, and this case might have gone back to the PUFS days. If you look distally, you can see basically the coverage that you get with a single device. Now, remember, these are the platinum braids. And so within each cell are an additional 3 strands. So we're really only looking at the marker strands here. You can see where you start to add them up, and this is also 3 stents going across this large aneurysm. It chops up the cell structure. And so by using stents of different diameters, you can make a somewhat complex coverage. Now, why is that important? If you think of classic flow diversion, the way flow diversion is kind of defined in a sort of mechanical method, and this has been well sorted out with engineers describing it mathematically, but it really comes down to momentum exchange across the sleeve of this construct. And so you have 2 components essentially to flow. One is going to be the convective inflow into an aneurysm that gives rise mostly to the vortical flow. And then there's a diffusive part where the fluid is diffusing between the 2 chambers or the 2 domains of either the vessel or the sac of the aneurysm. When you put a flow diverter, you are diminishing the convective component of exchange, and you're biasing the exchange toward diffusion. And the more you add, the more biased it becomes to diffusion. Now, why does this become important? There was some nice work done at George Mason University at the very early days by Juan Sobral, and they looked at transmural resistance across a construct. With a single device, there is no measurable transmural resistance because it's a very porous kind of structure. So you have a cell structure and it has a certain porosity. And it's not until you get up to about 3 stents that you can actually measure the resistance across the wall of the construct. So the transmural resistance. That has an effect on, once the aneurysm thromboses, on the exchange. Remember, a thrombosed aneurysm, you can think of thrombus as just a gel, or it's another kind of fluid. So just because an aneurysm angiographically occludes does not mean it's still not an exchange with the flowing blood within the vessel. And it's not until you get an intimal overgrowth that you actually seal that exchange and extinguish that exchange. And that's the point at which a thrombus aneurysm can begin to involute. We think that of that as being very important. But as we go through this talk, it's important to understand what you're doing with multiple devices. What you're doing is really increasing the thickness of the construct, the wall of the construct, and that has physiologic implications in that you're changing the resistance of exchange. You can apply that in a variety of circumstances as we go forward, and we'll show you some of these cases.
So something else that I think is important, when we talk about efficacy, like flow diversion changed the way I think aneurysms are treated all over the world. But why? Okay, why is many reasons why. One reason is that it's very effective. Now, how do we define efficacy? There are two ways. You can think of an efficacy from an angiographic or anatomical perspective. Is the aneurysm completely closed? Did the aneurysm shrink if you do cross-sectional imaging? So that's an anatomical definition of whether it succeeded or not. And then there's a clinical definition. Did we protect the aneurysm from rupture? Did the mass effect go away, right? That's a clinical kind of endpoint. In the angiographic world, the purest way to think of it is complete versus incomplete. It's either it's closed or it's not closed. Complete is how you kind of like go with trials. So if you're going to design a trial, usually the FDA will require a core lab to adjudicate it as complete versus incomplete. If there's any remnant, it's considered incomplete. Now, why? Because adequate occlusion, when we talk about adequate, just think for a second what that means. It's not an angiographic term. It's a clinical term, right? It's adequate is a state of mind, meaning it's adequate for whatever I think is my goal, like it didn't rupture, but it's something else, but it's not a complete angiographic occlusion. So something that you should keep in mind when you think of how to define success versus not. Now, clinical efficacy, as I said, for most aneurysms that are small, that have no mass effect, the clinical efficacy is basically protection against rupture or re-rupture if it's a ruptured aneurysm to begin with, right? Now, for most small aneurysms are very unlikely to rupture in the first place. So I think clinical efficacy of flow diversion is excellent. Now, for the ruptured aneurysms, at least in how we work many times for endovascular approach, we have what's called the plug and pipe technique. And a ruptured aneurysm is secured with some sort of endoluminal endosaccular treatment, coils or web or whatever it is, RTs, whatever you want to put inside. And once the patient recovers from their subarachnoid hemorrhage, we then use a pipeline or another flow diverter to secure the aneurysm against recanalization and recurrence, which is the problem with coiling specifically, particularly in other methods too. Now, it's harder though. That's the bulk of aneurysms we treat. For mass effect, I think it's a much harder problem because the aneurysms are usually much bigger. They're more aggressive. They've gotten to that size, obviously, where there's others have not. So they've already demonstrated that they have a more aggressive biologic behavior by having attained the size that they have to cause the mass effect, okay? So reducing that size of the aneurysm and reducing the mass effect is a more challenging oftentimes. And that requires like a different strategy. Many times using multiple devices, using some of the things that we will mention. So that clinical efficacy in terms of mass effect is often more challenging. Okay, so this, Dr. Nelson spoke about it, this kind of aneurysm. And this is what is classic flow diversion, right? You have a cavernous aneurysm, there are no outflow branches. It's kind of, you know, this is where flow diversion was tested and proven. This is another one. So here you have you can call it a supraclinoid or paraophthalmic aneurysm, depending on how you classify them for yourself. And it's the same strategy, right? There's no outflow branches here. Here's the ophthalmic artery arising separately from the aneurysm. And you see, like before, just like what Dr. Nelson discussed. It's the same approach. Multiple overlapping devices across the aneurysm neck, less coverage of the ophthalmic artery because you don't need to cover it, right? So,
And again, just drawing your attention, it's important to remember that the exchange into a blind sac of an aneurysm fundus is really characterized by the momentum exchange between the flowing blood in the vessel and the sac, the closed sac of an aneurysm. So we have to consider the convective forces and the diffusive forces. That changes when there's a runoff vessel. Like, why does the ophthalmic artery stay open when an aneurysm might close? It's because flow into that vessel is really defined not so much by momentum exchange, but by a pressure gradient and resistance. So down a channel, like an ophthalmic artery or any artery, flow in that artery is determined by the pressure gradient and the resistance to flow.
okay, so this is, and this is, you know,
The classic.
I'm sure you've seen these pictures. This is why flow diversion changed the world. It's because of results like this.
And it was usually even people that were sort of resistant to it. It was the 6-month follow-up angiogram that was so like convincing. Anyone with experience coiling an aneurysm like this understands what you're likely to see in 6 months, a recurrence. Clipping this aneurysm can be kind of difficult, but when this result, was seen in the follow-up angiograms, people became believers, and that's why it became so powerful tool.
So here's another example, large cavernous aneurysm. And there's many points here. Like, for example, one of the points is that if you notice here, the artery, the horizontal cavernous segment is compressed, right? Oftentimes when the aneurysm is large, it compresses, uplifts and compresses the artery here, ovalizes it. So in a different projection, it'll more likely to look like an oval. As the vessel heals after flow diversion, the artery diameter returns to what should be its kind of native normal size in many cases. So not only do we have the aneurysm that disappears, but also the artery is more
Normalizes.
physiologically normal. And now, I'm showing here the CT. You look at the CT, corresponding CAT scan pre and post treatment, because for the large aneurysms, for the ones that cause mass effect, it is extremely important, as Dr. Nelson mentioned earlier, not to rely on the angiogram alone to tell you whether the aneurysm is closed or not. Because an angiographically closed aneurysm can continue to enlarge, can even rupture sometimes. So the importance here is that you have to have cross-sectional evidence that the aneurysm is shrinking. Now, once you have that, that is extremely powerful data that the treatment is working. Even if the aneurysm does not completely shrink, the fact that the aneurysm is decreasing in size, and many of them do, especially the larger ones, tells you that you've changed the biology, you've changed this, for whatever reason, there's less transmural pressure, there's less, and the aneurysm ultimately will shrink. And that's where the mass effect, of course, is improved.
So this was just the PUFS trial. What was unique about that trial in our field is so much of interventional neuro is supported by anecdotal evidence and trials with incomplete follow-up. So when we did the PUFS trial, we made it an all or nothing. So there is no grading scale for how much is an aneurysm closed. Is it like a little neck remnant? Is it a big neck remnant? Raymond 1, Raymond 2? It was either closed or not closed. So it was a binary choice, which improves your ability to score the outcome, number one. Second, if a patient failed to show up, they were counted as a failure. So the treatment result actually was better than was reported, because some of the patients that didn't show up for their 6-month angiogram were calculated in as failed aneurysms, even if they then returned at 1 year and were shown to be occluded. So The trial, I think, the importance of it, other than validating flow diversion, was that it was a very robust trial. There was virtually complete follow-up, and anyone that didn't follow up was counted as a treatment failure, which is unique in the field and unique in even for flow diversion trials that came after this, where we've gotten a little sloppier in terms, or a little more liberal in terms of what we accept as a good outcome or an acceptable outcome, as Max was talking about. This was all or none. It's either closed or it's not closed. And if the patient doesn't show up, they're counted as a failure.
For those of you that may not know, PUFS was the trial that led to the approval of pipeline in the United States. So an FDA mandated trial to bring the first flow diverter, which was pipeline device, to the US. There was another trial before that called PETA, and so there's a history of that. And there's a flow diversion-like device called Silk that was available here. So it's not, there's more to it. But what really kicked off the era of flow diversion was PUFS. Because once this was approved in the United States and became available worldwide, that's really when, when that curve, that utilization curve started to go up.
And the other thing about PUFs that would distinguish it from the earlier trial, PETA, which led to European CE marking, was that you could not use coils in this trial. It had to be flow diversion only. So if you used coils, it was counted as a treatment failure.
So we can maybe skip this over because we're going to show some cases. So you can read all of this.
Cases are more important. You can read
Cases are more
it.
important. Now I think this is important because this is a publication that followed several years after PUFs. Because you always learn more from failure than you learn from success, right? Like why do some aneurysms fail to close with pipeline or other devices? And there is it's not magic, like Kim says many times. You have to understand the anatomy, you have to understand the tool. And so once we understand that, we can predict, we have some way to predict what's more likely to work, what's less likely to work, right? So in looking at this, in looking at the reasons why an aneurysm might stay open after flow diversion, the most common by far, the most common reason is an incorporation of a branch into the aneurysm. You all know this, right? Like at that time when this was published, like this, most people didn't understand. Now it's obvious to most of us that if there is some sort of outflow source for the aneurysm, that might keep the aneurysm alive in some ways, as Kim was mentioning. So that is very, very important. And that's, again, like goes back to what I was saying earlier. It's not so much where it is. Is it in the cavernous segment? Is it in the ophthalmic segment? That's less important than is there a branch associated with an aneurysm? How big of a branch that is? How good is the collateral potential of that territory? The more the collateral potential, the more likely it is that that branch is going to close because the collaterals are going to take over. The less collateral potential, the more likely the branch is to stay open and the aneurysm with it. So this is moving from like a purely surgical anatomical location to a more vessel-based analysis. And so here, you're looking at this like classic, like this is classic flow diversion, ophthalmic aneurysm. But no, you have the ophthalmic artery incorporated into the aneurysm dome, right? That's very common, right? For ophthalmic aneurysms, that's very common.
And let me just comment, because this is one of my early failures, a frustrating failure, lovely lady. And I started, as was my habit, with overlapping pipeline devices here, not recognizing at the time that, again, because this ophthalmic artery is coming off the sac of the aneurysm, that I can't treat this aneurysm as a blind sac. And so all of the momentum exchange theory goes out the door because there's a runoff into the ophthalmic artery that's going to be dependent on basically the pressure gradient in the ophthalmic vascular bed and, of course, across the wall of the stent construct and the pressure gradient. So this is her at 6 months follow-up. A smallish aneurysm I thought for sure was going to be closed. it's alive and well. So we continue.
And then you see the aneurysm is alive, right? But you also see the ophthalmic artery. So it's marked here. The outflow of the ophthalmic is from the aneurysm, and so they're both alive. Now,
So we put in more PEDs. I think I took her up with an additional 2, so we ended up with 4 PEDs in this small aneurysm. Now she comes back for follow-up, and this I think was 5 years later, we get the follow-up, and the aneurysm finally is occluded. Why is it occluded? Okay, because there's no antegrade runoff in that ophthalmic artery. It's finally developed a collateral circulation. So we finally make enough resistance across the wall of the construct. With 4 stents, you're going to get some resistance, that you change the hemodynamics of the orbit. So the watershed zone between the external carotid contributors and the ophthalmic off of the ICA changes and moves toward the origin of the ophthalmic artery. And you see here with the arrows that the ophthalmic artery is retrogradely filling from the anterior deep temporal, the meningo-ophthalmic. And so finally, the aneurysm is cured. But what was important about this, other than sort of understanding how an aneurysm treatment with a flow diverter can fail, is it gave us insight into vascular rearrangement as a therapeutic goal. So where you come to situations of finding an aneurysm with an outflow vessel, you don't have to give up. You can begin to think about, how can we do this? Like the lady did not lose vision here. How can we do this? How can we manipulate the vascular circulation to effect a treatment?
So basically, and this goes by many different names. So different people like kind of thinking about this problem, they might call it flow rearrangement or flow remodeling or something like this, right? But there is this concept that when we doing quote unquote flow diversion, we are changing the hemodynamics of not just the aneurysm, but the vascular beds that may be associated with the vessels that are around the aneurysm, that are incorporated into the aneurysm or quote unquote covered by the pipeline device. So this becomes kind of something that people need to accept, that there's going to be some remodeling, that the vessels might change, that an artery that used to come from one place, that territory might be supplied through another territory. That is a key prerequisite of many of these kinds of treatments. And some people are willing to do that, and other people are not willing to do that. They'll say, no, I don't want to have an aneurysm. I don't want to lose this branch. I'll use some other method to preserve every branch as it was kind of originally, as you found the anatomy in association with the aneurysm. So that's more like a conceptual difference of the people that are more accepting to do advanced flow diversion or less. And we can get into that discussion more. Now, I want to say one thing more about this. When I presented this in Val d'Isere many years ago, there was a big discussion. And the point of the discussion was to talk about why this aneurysm did not close, okay? Because there was an outflow branch, right? But the discussion got sidetracked. And most of the discussion in that session was not about this. People started raising their hands and saying, well, why did you retreat this aneurysm? It was never going to rupture. It's a small aneurysm. Why did you put more devices in there? Why would you do that? And here we go back to what is the efficacy. Is it clinical efficacy? Is it angiographic efficacy? Here, I'm not disagreeing that had we left that aneurysm alone, the risk of rupture of that aneurysm would be extremely low. So, but the point is not that. The point is that this case illustrates a concept that is applied to any kind of aneurysm. It's one thing to talk about this little guy. Now, you're going to see aneurysms that are much, much bigger, where you don't really have a choice. You have to carry it out to completion because of mass effect, for example. And so there, application of that principle becomes key.
And then extending the principle, is it so radical? Like there are many people that have seen this case, or well, what's the risk of blindness? What's the risk of this or that? And I think we now have enough experience to say that it's a very, very low risk. But this concept has been around a long time, as long as interventional neuro has been around, because this is what we do when we close a carotid to treat a large cavernous aneurysm. You're dependent on the circle of Willis and rearranging the supply to that ipsilateral hemisphere. So conceptually, this derives from the early days, the history of intervention. It's just a more sophisticated application of the same principle.
Okay, so now this particular, so this is more of a technical point, and I think it's important. And we were discussing this point earlier today in one of the aneurysms that we're going to treat. Is this anatomical arrangement where you might, when we're talking about incorporating a vessel, secondarily, if you will, into the aneurysm sac. So if you're treating this aneurysm, where the ophthalmic artery is not directly part of the aneurysm dome, but if a device is placed like this, which is suboptimally placed, right? Device is not fully expanded, not opposed to this portion of the wall, then what might happen is now we've created a kind of aneurysm that incorporates the ophthalmic artery into its neck, right? That wasn't the case before. And so here, this is where the technique becomes important. We're understanding this idea of outflow vessels and why things fail informs us of how to better use the device. What is the technique? What is the goal? The goal is that you have to expand the device well enough to oppose it to this point so that like it maximizes your success. And this is the example of what happens when you don't, right? So this is the example. This is a quote unquote failed case. Ophthalmic outflow now from the aneurysm because of how the device was not positioned optimally here. Okay.
So the only way to address that is similar to the other case where the ophthalmic was coming from the sac of the aneurysm, and you have to you have to change the hemodynamics so that the ophthalmic artery fills from elsewhere.
Now, this particular one, again, illustrating, this is what's called internal control. This is one patient having several, like kind of a dysplastic carotid, sort of carotid siphon, if you will, having multiple kind of separate dilatations, but really all deriving from a dysplasia of the siphon. Now, you see these different bumps, right? We're going to treat them all. So we're going to put a construct, a flow diverted construct across these, and look what happens, right? What happens is all of the ones that weren't incorporated with the ophthalmic artery have gone away. The one that remains is the one with the outflow to the arteries. So that shows you that within this one person, right, there's an internal control. The ones that close are the ones that don't have the vessel. The ones that, and this one stays open. Okay, here's another example. If you look at this 2D image, okay, well, it looks like a typical, like sort of your classic flow diversion case, right? Now, if you have 3D, if you have Dynacity, of course, it's helpful. And so the more you look at it, you start to look, interesting. So this diameter here is kind of blown out, right? There's like a fusiform component, almost 6 millimeters. Now the pipeline goes up to 5.25. So it's not, doesn't expand to 6 millimeters. So if you look at this, you start to think, okay, like this, because of this issue, because of this diameter, and the ophthalmic artery that's incorporated into this fusiformly dilated portion of this kind of segmental dysplasia of this segment with this arrangement, now you think, okay, this is may not work so well, right? Why? Because of this problem. And so indeed, there's a couple of devices placed, balloon expand, making sure that like we do as much as we can. But at the end, despite a couple of devices, the aneurysm remains open because of this arrangement that you saw. Okay, at 12 months, same thing. Now we can do a more fancy sort of evaluation of this, do like a, basically what is it, cone beam CT. Now you see the rearrangement, and it goes back to what we were talking about. There's a rearrangement of how the ophthalmic outflow is now arising from this dome, wrapping around the device construct, and then coming out. But the similar idea that we have a diameter here that's too large for this device to ensure success. That's the same concept here. Now, if we're talking, again, going back to this idea, it's about vascular environment, not about the anatomical location per se. So when you talk about PCOMs, a PCOM aneurysm, when we think of PCOMs, what primarily drives kind of our decision many times is what is the status of the P1 segment versus the posterior communicating artery. Is the PCOM quote unquote fetal or not, right? In the fetal PCOM, the efficacy is less. Why? Because of the things that we talked about, because the outflow into the posterior communicating artery maintains patency of the aneurysm, whereas if you have what's not a fetal posterior communicating artery, if there is a P1 segment, then once we use flow diversion, then the PCOM shuts down and the P1 segment carries the flow. Similar, the same anatomical arrangement, analogous to what happens with the ophthalmic artery. An ophthalmic artery with good collaterals is going to shut down with the aneurysm. An ophthalmic artery with poor collaterals is going to stay patent and keep the aneurysm alive. So this is an example of a classic PCOM. Okay, we have on the right side, we have a good posterior communicating artery and a good P1 segment. So this is a right-sided aneurysm. And so, okay, we use this. What happens? The aneurysm is occluded. The posterior communicating artery is occluded. The P1 segment supplies the posterior cerebral artery and retrogradely supplies the posterior communicating artery territory, right? This is classic. Works very well. This is, again, one of Kim's cases, and this is an article about kind of reduced efficacy of flow diversion with a fetal posterior communicating artery.
So how can we address that? Well, then now you need to go back to your embryology. And when you think about how vessels develop, there's tremendous variation in the circle of Willis, for instance, in this case. Sometimes you have an atretic P1, sometimes it's hypoplastic, sometimes it's dominant. And so recognizing that and understanding what the potential is, and knowing that over periods of time, you can safely rearrange the circulation as long as there's some fundamental embryologic vessel to work with, can inform you on how a strategy to change an aneurysm and to do it. So basically, these are the three kind of boundary conditions. This is the case that we have of thrombosed complex PCOM aneurysm. This was back in the day when we have a vascular conference that we show. We discuss these cases. Should it be clipped? Should it be coiled? Should it be by this time we had pipelines. So now we were thinking about flow diversion. None of the surgeons really wanted to attack this in an open way because you can see that the aneurysm sort of complexly involves the entirety of the PCOM segment. This looked like a fetal PCOM. There was no angiographically apparent P1. These are the superior cerebellar segments here bilaterally. And so the question was how to go about this surgically. Coiling probably is not going to be a solution because there's going to be part of this fundus neck that you can't completely occlude without jeopardizing the aneurysm. And so we elected to try to stage this and change the circulation. And so we dropped two pipelines in, and that's this construct that goes in. And this is basically the immediate afterbirth. You see the stagnation in the sac of the aneurysm. And this is after two pipes, still, it's not looking very good for a P1 segment. Still, the PCA fills mostly through this vessel. And now this is coming back 3 months later. And there's a change here. It's still the PCA is filling principally through the PCOM, but there's some washout here. And so now when I shoot my angiogram, I see there's a little teeny P1 segment that has increased in size from its embryology. Like it was there as a little teeny capillary, but it's slowly changing. So now we put another two pipelines, and this is the 3-year follow-up angiogram. Aneurysm is finally occluded. PCA fills through this enlarged PCA. And just like the ophthalmic segment where we showed this ophthalmic artery where we showed over time you can rearrange the circulation, we've treated this aneurysm by rearranging the supply to the posterior circulation that wasn't there initially. So if I clipped that and closed that vessel, I probably would have had a PCA infarct. But this way, by staging it, you can address this aneurysm over a slower period of time, kind of like a Silverstone clamp in the old days to close a carotid artery, and slowly go about rearranging the collateral circulation. Okay.
One of the kind of one of the important factors in any of these sort of treatments, when we talk about these more advanced rearrangements, fetal PCOMs, and things like that, what in terms of safety, what's critically important is to have a very good, adequate antiplatelet state. If you look at the sort of hemodynamics, flow dynamics of what happens to quote unquote a fetal PCOM or an M2 segment that's acutely, covered or jailed with a pipeline device, from purely the standpoint of hemodynamics, the probability of an acute occlusion of an infarction, of insufficient flow into that territory is practically zero. How people come to have a complication is when thrombus forms on the mesh of the device and then completely closes the artery. And that would happen if the antiplatelet state is not adequate. So one of the many things that we've learned, as many of you know, in this experience, is that often clopidogrel is not the right drug for this. There's a lot of resistance to that. We test for it, but many places don't have that ability. So here you use Brilinta many times. And so, however we ensure that there is very good antiplatelet coverage, you have to ensure that. Otherwise, this thing is going to have you're going to have problems if you don't ensure this. And the other thing that's important, practically speaking, is that no matter how many people take whatever medications, once in a while, you're going to discover that you put a device in there and you see that thrombus starts to form. Why? Maybe there's resistance to Brilinta. It's very low, maybe 1% or less, but it exists. Or maybe the medications weren't taken, or for whatever reason, a thrombus starts to form. So what do you have? What to do now? You have to have an intravenous way of dealing with it in a very expeditious fashion. So 2B3A inhibitors like Integralin or Agrestat or something like this is key. If we're going to do this without these medications, the probability of complication is significantly higher. And so in order to do this, we have to have the right setup. And I think that's now available here in the labs that do this.
And that's just her follow-up CT showing that there's no end.
Okay, now just to take this like one step further, if there is like, let's say what happens if you put in, you're limited to one pipe. You don't want to put in two, you can't afford two, whatever, don't have another one. Practically, that's important. Put one in, aneurysm is still open. Okay, what are the other options that you have? Well, the other option is to do something like this, right? Wait for the P1 to grow up, come back through the posterior circulation, coil off the aneurysm. Do something like this, right? So here's an example of that. This aneurysm here is already coiled. It's coiled because it was ruptured. It was coiled in the acute setting. And so now we have a coiled aneurysm. And as you see, like often, there's a little neck here. Now, in our practice, when it's a ruptured aneurysm with a residual or recurrence, we don't observe it. If at all possible, we want to close that aneurysm. And usually the answer to this is the plug and pipe. The answer to that is flow diversion. So we place, there are some other aneurysms there. You see one was treated with a web, another like pipeline on the other side. But on this side, right, we place a pipeline. There's a very small P1, so we do something like this. You see like there's a pipe here, coils. Now, 1 year afterwards, what do you see? You see that the aneurysm is still alive, right? But the flow into the posterior communicating artery is less, and now there's more washout. Understand? So if you go back here, if you go back to this picture before the treatment, There's much more contrast that you see in this PCA, right? A year later, much less. Why? Because the P1 has gotten bigger. And mostly it's the P1 that's now supplying the posterior cerebral artery. Right? So what does that mean? That means that the P1 is large enough that we can now go back through the P1 into the aneurysm and coil off the rest of that. Okay, everybody, so you want to understand that. That's another strategy.
And close the PCOM if you need to do that.
Okay. Now, if you're doing that, actually one important aspect, one important anatomical aspect, if you're going to do that, is you have to understand where the perforator to the thalamus comes from. Sure, you know, like surgically also, that pretty much every time there's an anterior thalamoperforator that arises from the posterior communicating artery, right? And that's a very important artery. That thalamoperforator is very important. So if we're going to coil this, we don't want to close that with the coil. Sometimes it kind of arises more proximately off the PCOM, sometimes more distally. So you have to be careful. Get an angiogram through the microcatheter, understand what we're closing, and then go ahead and do that if it's safe. Okay. So here's another case. Like maybe we can skip over that. Should we talk about ACOMs maybe? Okay, so maybe there's so many more cases. This can go on for a while. But ACOMs is another area where I think we've been using flow diversion in various aspects that I think is better than this was a few years ago. Eitan Raz, our colleague, did a poll saying, well, how many people treat ACOMs with flow diversion? It was basically less than 10% or none, right? Now things have changed because it is a powerful way to address anterior communicating artery aneurysms. Now, why? Because there's so much variation, right? When you think of ACOM, the artery itself is tremendously variable. You look at all this, like these variations. Look at this paper. They counted 27. Guess what? There's 27,000. You're going to dissect more cadavers. You're going to discover more anterior communicating arteries, right? It's just the notion that there's just so many fenestrations, duplications, and so forth. And so these oftentimes complicate our treatments of ACOM aneurysms that arise from like these messes that you see there. Okay, so now, again, you think vessel, like think of arrangement, like how does that work? Well, the way that works is we're going to place a flow diverter from the A1 to the A2 segment, right? Now, in a situation like this, where you see like the middle picture, it is often sufficient to just do it on one side, to just place it ipsilaterally from the A1 to the A2 on the dominant side of the A1. Now, in a situation like this, it's frequently necessary to do what's called an H pipe, so A1, A2 on both sides. Now, a situation like that is where the debate is. Like, do we use that or do we use something else, like a web or Artis or coils or stent-assisted coiling or whatever? Many ways. In fact, yesterday we were kind of like recapitulating that in one of the aneurysms that we had treated. So here, there's a little bit more kind of debate, but definitely these are good targets for flow diversion. What is the advantage? The advantage is we don't have to worry about exactly what the anterior communicating artery looks like, what are the bumps and the lumps and the aneurysm. It's really about rearranging flow as opposed to going into where the aneurysm is. Now, this is very well known, right? You take like this huge complex aneurysm, you have an A1, ACOM. Okay, so what happens to treat this aneurysm? We have to extend our device into the MCA, right? And so once we do that, okay, this is what happens. It's a great outcome. Here's, by the way, the choroidal artery continues to be patent. And so what happens? Once this is extended into the MCA, usually the A1 shuts down. There is a rearrangement in flow, bilateral anterior cerebral artery territory supply through the ACOM, right? So that's like bread and butter. Now, same thing, that's the same idea that you're now applying to the treatment of an aneurysm like this. Exactly in this fashion. And this is what often happens. It doesn't always happen like this, but it often happens this way, that with just one device, you can make the ACOM aneurysm go away. This is an example of that. So you have a large aneurysm, small a1 on the left, pretty dominant on the right. This is coils and pipeline together, right? Now, what happens 1 year later? You see the aneurysm is gone, but you see less inflow again into the contralateral anterior cerebral artery. If you go back to this, this is what was before. That's how you see it now. Predictable, right? This is highly predictable that this is going to happen. What's going to happen is that the A1 on the left side is going to grow before, now, much larger, predominantly supplying the anterior cerebral artery territory. And that's the concept. That's how you think of like treating an anterior communicating artery aneurysm. Another example, subarachnoid hemorrhage, small aneurysm, typical your small ruptured ACOM. Now, if you do this, if you do DynaCT, you understand the complexities of all these lumps and bumps and fenestrations. Okay, what to do? Like again, relatively simple, two-staged approach. Coil, suboptimal coiling, right? This is plug and pipe approach. We're not worrying about this neck. This is at the beginning, there's a remnant. You can see that. Why? Because we're going to come back later, 1 month. Sometimes you can wait. You don't have to do it in a month. You can do it 2, 3 months, depending on, there's not like a prescription for that. Then you do this, right? This is the remnant. Here's the device. This is the outcome in the end. Aneurysm is shut down. So that's your classic plug and pipe.
And the purpose of it is to prevent the recurrences in both of those ACOMs that had been coiled for one reason, rupturing and things like that. The question is, why come back and do this? It's to prevent the recurrence that is coming. This was very complex. You just coiled the little blister dome, left the base of the aneurysm, but you can address it this way, and you didn't have to pay attention to the fenestrations in the ACOM at that point. It becomes a much simpler anatomic approach that leads to a cure of the aneurysm.
Okay, so this is, again, what happens if it doesn't work. You can come back, treat the other side. One of the questions that frequently arises is, do you do them both at the same time, right? Or do you wait, like do one side at a time? I think it kind of depends on your approach. I don't know if there is a right answer to that. The more conservative way is to do it one side at a time. So should there be some sort of complication or an issue on one side, and you have to like worry about the antiplatelet coverage, modify it, it's much easier to do that if you only have one side at a time. So that might be the more conservative approach. If you're just starting to do this, maybe you want to see how it works. Put in one side, wait, put in the other side later. That's another. So again, you think vascular anatomy, not location. So PCOM showed you what happens with the PCOM. Same thing you can do with ACOM, right? Come back, coil up against the pipeline. There's no issue. Then the coils are not going to prolapse into the left side. Coil off against the pipe, cure it that way. So there's like an example of that here, so forth, right here, like this. Okay, showing you small ones, but like maybe we're probably going to wrap up in a little bit. Now we have something much different, right? I think this is Kim, this is one of the cases that you've done.
So this was a gentleman that actually came in with hemibolismus and cognitive decline, and it was obvious when they got the CT what was going on here. And this is a very large calcified, mostly thrombosed aneurysm in a gentleman with Mass Effect symptoms. So how do we deal with that? So the upper panel here, this is the MR. You can see there's a lot of edema, surrounding edema, in this aneurysm, and really just kind of a small piece of the aneurysm, at least as suggested by MRA, that's still filling. And again, this just to kind of regurgitates the whole notion that a thrombosed aneurysm is not necessarily your friend, because the thrombus, which is just a different form of fluid, is still in exchange with this flowing blood in this residual pouch. And so this is angiographically what it looks like. Now, again, this is a situation where you have both distal ACAs arising from a dominant left A1 segment, and you can see that the right A1 is atretic. So how to go about treating this? Well, we wanted to explore it. So we do, balloon test occlusion. This is the balloon in the A1 segment on the left. Now we simultaneously shoot these ICAs bilaterally, and you can see that there's quite a bit of good collateral support for the distal ACA territory. So one of the treatments, thinking kind of back to our deconstructive approaches of history, is to close at the aneurysm level, to close the ACAs and address the aneurysm in that deconstructive way. And so that gives us, one opportunity, so we explored it further with microcatheterizations and decided that, well, let's see if we can keep this open, perhaps, and try to get some symptomatic relief, and we'll address it with pipeline. We'll have to jail one of the sides here. But we know that we can always come to an occlusion of this vessel if we have to. And so this is just the flow diversion effect. You see the stagnation and the contrast. We drop 2 pipes across here, jailing the left A2. And this is what it looked like immediately after. You see there's contrast stagnation. This is a little bit later, follow-up 8 weeks later. We decided let's stage it and we'll add additional pipeline to this. And I have limited follow-up of a couple years in this gentleman because he died ultimately of advanced prostate cancer. But over a 5-month period, his clinical symptoms resolved. The hemibolismus improved neurocognitive function again. He wasn't bifrontal any longer. And you see the MR correlate of that even before the aneurysm completely shrinks down and disappears. The edema is much, much less. And this was the last angiogram that we got 6 months after the 8-week delayed, follow-up angiogram, just showing that angiographically we've closed the aneurysm. And we had MR evidence that we were on the right trajectory in terms of thing, but unfortunately he passed.
The kind of 2 other things to mention in regard to this case. So number 1, again, a flow rearrangement. If you look at this top row of images, you see what happens when you see how there's now, remember, the construct extends from the left A1 to the right A2. And so there's delayed antegrade flow, reduced antegrade flow into the ACA, into the left.
The jailed ACA.
The jailed left ACA. And we are encouraging those collaterals that you saw from the balloon test occlusion. They're kind of encouraged, and there's more kind of backfilling of the, particularly like the sort of distal, like cortical territory of the ACA through the leptomeningeal anastomosis with the middle cerebral artery. Now, this is not, and again, like this is, we're buying into this concept when we're doing this treatment. We're comfortable in stating to ourselves that this is different kind of physiology, that this is not some sort of like inferior type of arrangement. This is an arrangement that allows for the aneurysm to disappear or to shrink.
Right.
Now, the other point is this, like when people talk about treatment of ACOMs, there's often this idea, like, what do you do, ipsilateral A1, A2, or do you do contralateral, like what's called an X pipe, which is left A2 to right A1 and then vice versa. And I don't think we should be really dogmatic about it. I think they're both valid. We prefer to do ipsi, like left to left, right to right, because I think it's more physiologic. But it doesn't mean that here we did a contralateral one because of various reasons. Some of it had to do with just ease of catheterization. Sometimes the neck is more favorable this way. So I don't think one needs to be like particularly kind of dedicated to one approach or the other. They both, they're both valuable. Should we continue? What do you think we should? Maybe we can do this one case and then we can maybe wrap up, because that's a very interesting case.
So this is a different kind of case. It's a lady that came in with diplopia and a little unsteady gait. This is the initial aneurysm. I'll show you the angiogram in a minute, but it was a little complicated, so people decided, let's just treat this conservatively and watch her. She got a little bit worse with the gait, became, like left third nerve palsy became complete. And she comes back a couple months later, and this is basically growing. Now everyone is in a state of panic because it's an unstable aneurysm, and this is what it looks like angiographically. So there's a lot of variation going on here. You have the basilar coming up to the terminus. There's a hypoplastic P1 on the right side. It kind of exits through the superior cerebellar. And then on the left side, the superior cerebellar is involved in the aneurysm. There's a fusiform component that extends out to the proximal superior cerebellar. And your right P1 with a percheron comes off the fundus of this fusiform aneurysm and then runs out into a PCA with a small PCOM on that side. So the question is, how do you do this? You can't coil this exactly. Clip it doesn't seem possible. So an option might be flow diversion. Well, how am I going to build a flow diversion construct here? If I go in the sort of obvious way from the dominant P1 into the basilar and try to remake the artery here, I have two problems. We already know that if you have runoff vessels, but if you have a couple of runoff vessels from this sac, it's even less likely to close. Unless I stage it over an extraordinarily long period of time, but this is an aneurysm that's already showing me that it's unstable, it's growing over a short period of time. And so we started thinking about, let's combine reconstruction with deconstructive techniques. And so we did a lot of balloon test occlusion. This is, to complete, you want to do a complete cerebral angiogram to fully understand the anatomy. So this is the right carotid. She's got this dominant PCOM with, we already know, a hypoplastic P1 on that side. You can do some balloon test occlusion. This is on the left side, showing, she has that P1. So the aneurysm will fill if I close the basilar below the superior cerebellar segment. And so she'll fill that superior cerebellar segment retrogradely if we go about it that way. So we did a lot of test occlusion. We went into each vessel. And what we found is that the collateral circulation over the cerebellar hemisphere was somewhat favorable in the left superior cerebellar artery. So the first stage of the treatment became, after doing all the balloon test occlusion, let's acutely close this superior cerebellar segment. And we did that with an MVP inside a pipeline that we shoved into the proximal basilar artery. And so this is occluding, and you see the superior cerebellar filling retrogradely here, coming up over the hemisphere over time in a serial radiographs. It's flowing backward like that to the point where it's occluded. And you can see the follow-up MR. There's no stroke. Now she comes back a month later, and you see already the thing is still growing. Its evolution, so it really is an unstable aneurysm. We've closed off the superior cerebellar antegrade, but now we're going to complete the reconstructive part. And we had decided, let us go into the superior cerebellar on the right and reconstruct a vessel from the basilar to the superior cerebellar, jailing the left P1 segment that's coming off the dome of this aneurysm. And so that's this construct. We have the occlusion devices in the right superior cerebellar, the left superior cerebellar, the pipeline construct going from the right superior cerebellar into the basilar, jailing the basilar terminus. And this is what all of the fancy catheterizations, you had to go loop to loop. It wasn't so easy. And then deploying the pipeline. Now this is her 3 months later, bring her back in for an angiogram. These are the occlusion devices. Here's the reconstruction from the right superior cerebellar down to here. And that's what it looks like. This is angiographically what things look like. Looks very promising, runs off to the sphere cerebellar. But where is the basilar terminus and the left, the PCAs? Well, we know we had good PCOMs. This is the PCOM on the right side. And then you notice that the P1 segment fills retrogradely to the percheron that we had there. And then on the left side, that dominant PCOM fills the PCA on the right side. And then this is the vert injection, just showing it runs off to there. But what's the proof of the pudding? That is in the MR. We already know we have a lot of mass effect here. This is the pre, and this is at 6-month follow-up, the dissipation of that mass effect. And so the tool is fantastic. You can reconstruct things, but it's important to put it into a framework of the philosophy of endovascular. And sometimes you're going to want to, as part of rearranging the cerebral circulation, you're going to want to combine your historic deconstructive approaches with your reconstructive approaches to arrive at a therapy. Thank you.
Yes, thank you. One more case, maybe, just one more, because I want to finish, because I want to just kind of, some cases we didn't discuss, but we can also want to, again, when we think about all the things and showing all the applications of the device, sometimes it may not be the right tool too. So I'm going to show just one case that where we elected not to do flow diversion for different reasons, but still underscoring that even though we're not using the pipeline or whatever is your device, the principles of circulatory rearrangement still apply. And you can apply principles not with this tool, but with surgical tools and so forth to address something like this. So this is a gentleman comes in with this thing, acute headache, and this is a rupture. So you see there's some subarachnoid hemorrhage, but underlying it, there's some giant mass with sort of like laminated, sort of different densities inside, edema posteriorly, edema anteriorly. And so this turns out to be this giant, partially thrombosed middle cerebral artery aneurysm that's now acutely ruptured. Now here, if you're, again, if we do a lot of cone beam CT, and so if you're using this kind of powerful imaging, you get additional insight into aneurysm biology, which is kind of like pushing the field forward. And so if you look at this situation, you start to see a couple of like interesting vessels here, like kind of straight, sort of, you might think that there's there's thrombus here in between the aneurysm and these things. And so, like, are they lenticular striates? What could they be? Now, if you work it out, and here you really need this kind of dyna CT for Siemens, or like cone beam CT is the overall term. Once you work this out, you realize what these are vasorum, and it's a known concept. It's a known kind of entity that some aneurysms, particularly these kind of complex, large, laminated kind of aneurysms, have vasorum, vessels that supply the aneurysm wall. And so the wall in itself becomes its own living tissue, right? Like how do aneurysms grow? What supplies the aneurysm wall? Like that's a whole other, topic. But once the aneurysms get that big, the vasorum in them also get bigger. And so big enough for us to appreciate them angiographically. And so you see, now you start to think of like, okay, well, so why are some of the treatments fail? It could be that in an aneurysm like this, the wall has become its own living thing. And so it's important that these vessels be closed in order that the aneurysm ultimately be taken care of. And there's some beautiful examples of selective embolization of these vessels. Sometimes it's possible to selectively embolize the vasorum even. So that's a whole other kind of like talk about the biology of various aneurysms. And so here you can work them out. You can see, looks quite beautiful. And so here, when you're thinking of this ruptured aneurysm, vasorum, lots of mass effect. Okay, maybe this is, what other options do we have other than flow diversion, right? Okay, so here you see from this picture, we're getting ready for bypass, right? So we're going to use more of a reconstructive, deconstructive strategy. So here you can do this. If you, again, if you have cone beam CT, you can kind of map out. You look at your STA, you can see what MCA vessels are underneath, so you can kind of help yourself figure out which one you're going to hook up to which one. And so ultimately, again, we do a balloon test occlusion because maybe there is a deconstructive option like that. We elect not to do that because without a bypass, because there's not sufficient flow into the superior division here. And so what happens is here's Dr. Nosik's bypass, STA, kind of your your classic ECIC bypass, STA-M4 bypass. You see that's filling out the MCA territory that is distal to the aneurysm, and that's followed by a deconstructive treatment. The aneurysm is the portion is coiled off, the patent portion. With extension, if you see this little extension, we're extending the coils into the MCA, into the parent artery from which the aneurysm arises, and occluding across the ostia of these of the vasa vasorum of this aneurysm like this. Okay, and so here's the immediate sort of post. So it's like post-surge. So there's a surgery. Here's the aneurysm. This is 2 months later. This is actually just a few weeks ago. We just put the bone back last week, right before we came here. Eris put the bone back on. But you see there's obviously there's been some recovery. The aneurysm is shrinking. There's still a little bit of edema, but the patient is clinically improving, and now we are ready to close the bone and allow for this thing to heal. Okay. So in the interest of time, we're going to kind of wrap up here. You can read the conclusions, and you've heard us talk. Ask if there's any questions or comments.
And I think the important thing is just to, yes, flow diverters are very powerful tools, but they're not a magic wand. You don't just put a flow diverter and expect the aneurysm to go away. It has to be used rationally within the context of your philosophical approach to therapy.
You told that after PISA and POX, FDA approved the pipeline for the carotid aneurysm. But instead, we have a lot of aneurysms, dissecting, microaneurysm, bifurcational, and we have no randomized trials. Can you comment this? Because these of label use,
Yeah. Right.
don't know where we should why we should look and where on the basis of scientific data.
Okay,
Yeah.
so just to rephrase, because if you're listening to the Zoom, you may not have heard the question. The question is that we have data for carotid siphon based on puffs for pipeline and other devices. What about lack of data for everything else? These ACOMs, pericallosals, how do we think of it?
So the two issues. Firstly, its approval in Europe was less restricted based on the PETA data. So the restrictions that people talk about with pipeline coming out of the PUFS trial was really an US FDA guidelines. In the United States, once a tool is approved through what is called a PMA pathway, physicians then are at liberty to use that device because it includes not just safety evaluation, but efficacy. A physician is then allowed to use the device off-label in other applications. But still, you might ask from an evidence-based medicine standpoint, what justifies it? Over time, and it was obvious from PETA because PETA were extreme aneurysms. I mean, PUFS was extreme aneurysms. The mean size was 18 millimeters. The neck size mean was 8 millimeters. It was obvious that it was going to work in small aneurysms. And so people started using it in small aneurysms. Ultimately, the FDA asked the company, will you please do a trial to validate it in small aneurysms? Because there are natural history trials like ISUIA that suggest, why treat a 3 millimeter aneurysm or 4 millimeter aneurysm? So that trial was done. It was called the Premier. And the results were even better. More occlusion, safer, obviously, because you're not having to do the gymnastics with catheterizations. And also our understanding of antiplatelets got better and all of these things. So finally, the FDA extended it to include small aneurysms, but still limited to the carotid ICA. And so now that's a question because we don't have good data on, okay, let's use it for a dissection, let's use it for ACOM, let's use it for PCA. And that is an issue, so I don't know what the answer is completely. I just feel, that it's evolving. Now no one wants to pay a lot of money to do a trial because people are using it for ACOMs or they're using it in these applications. So then it comes under the domain of what I like to say is the evolutionary pressures in medicine. Generally, what proves a therapy is its acceptance among the therapeutic community. And nothing stops a treatment faster than failed treatments. So I think we've entered now with flow diversion this domain where what will carry it forward in the future are just people proving to themselves that it works. Will we ever have a trial versus natural history? Probably not.
About like amplification aneurysm and dissecting aneurysm, because and for me, like dissecting small dissecting of this aneurysm is almost everywhere. It's given by
Yes.
diversion. Have no data.
Right. But will you ever have data for that? Should you have data for that? And so why have they adopted it for dissecting blister aneurysms? Because it's working, yes. As opposed to what they were doing before. And so now it's really evolution that carries it forward. Yes.
Yeah. Yeah, no, and it's a discussion that honestly, I think
It's a very good question because I think it's at the heart of how medicine advances at a certain stage.
But there's also like a kind of like a logical trick that's played on this. Because we're asking the question, what's the evidence for flow diversion? Why don't we just coil it? Now let's go back and ask the question, what's the evidence for coiling in all of these situations? And you're going to discover that there's no evidence for coiling there either. But just because it precedes flow diversion somehow, like it's enshrined itself as the, as the standard of care. So that goes into like, what is the standard of care? Standard of care is basically what people do. It has nothing to do with safety or efficacy, right? Like, look at the history of medicine. The history of medicine over like the history of humanity is a history of like standard of care, which we now, is constantly changing, and people will question our standards just like we question the standards of those that came before us. So this whole idea of like evidence, for some things there will never be evidence, right? Like we have to accept that, and we go with basically what, as Kim said, with what is known to work. And that maybe is the best that we can do. Any other questions? Okay, if there are no other questions, then again, we really would like to thank you for attending and for the Scheglov Institute for hosting and for RAZOM to enable this to happen. We're very indebted to the many people that have made this possible. And for the context, we're of course here to help you with, and to learn from you. By the way, the program that we are under is called Co-Pilot. And really the notion of co-pilot, that, of how experience is shared and how it's transferred and how, you grow generations. So, just think of like Kim as my mentor, and, let's say Kim is the pilot at some point. So like he wants me to be the pilot in some cases, to become the co-pilot and to enable the continuation of the field. We're not going to get into this discussion so much, but a lot of this, I think, is germane and important, particularly in this country. Like, how does neurointerventional training evolve? What are the conditions? Like, how to ensure that? And that's a separate talk, but what we believe is in the notion of co-pilot, that we support the development, that we're here to to create conditions for everyone to grow.
Yeah, I'd also have to say, for me, it's an honor because when I first got into this field, you know, Scheglov was putting balloons in aneurysms. It was very exciting times, and sort of just even conceptually paving the way that aneurysms could be addressed endovascular. And then his son continued on the work. So to come to this place for me is like historically important. I just was happy that I had the opportunity to come here. We've also collaborated with the group in Dnipro and, you know, seeing tragically the injuries there and dealing with that on an endovascular basis has been illuminating and quite a learning experience for us. So, you know, I'm very grateful for the hospitality here that you've shown us. And, you know, I just am happy that before the end of my career, I got to come here and to this very important place.
Okay, thank you. Thank you very much.